Greetings from Citizen Health Team under Academia IAPSM eConnect. We are initiating a series, People's Health, It Matters. And for this, today we have a very prominent speaker, Dr. Forhad Akhtar. He is an additional professor and HOD in the Department of Community Medicine and Family Medicine at All India Institute of Medical Sciences, Guwahati. He is a NARC assessor under UGC and was also the Medical Council of India, External Resources Faculty, and Observer for Medical Education Technology. A very warm welcome to you, sir, from on behalf of all the audience.
Thank you. Thank you.
And thank you so much for sparing time and talking to us and sharing your wisdom regarding the topic we shall take up today. As we are taking the topic today on tuberculosis, as we know that it is a disease which require a very kind, mean attention. And today we are taking the topic is tuberculosis control efforts in India and its operational challenges. Right, sir?
Yeah.
So just let's start with the question comes in my mind first that when we talk about tuberculosis prevention and control efforts in India, can you please tell me in brief the evolution of TB control program in India?
Fine. Thank you. So, if we see the history of tuberculosis control in India, it dates back to 1951. In fact, in 1947, along with the establishment of the Director General of Health Services, the TB cell was established. Then in 1951, we had the mass vaccination with BCG, and a national program was started in the year 1962. So in between 1956 and 1962, there was the establishment of the National Tuberculosis Institute at Bangalore. Then the TRC, that is Tuberculosis Research Center, which is now the National Institute for Research in Tuberculosis, that came up in Chennai. So all those things came up in between 1951 and 1962. So from 1961, the started the era of conventional chemotherapy, that is the long-term chemotherapy. In 1986 to 1993, we had the short course chemotherapy. Now, in the year 1993, the dots, which we know, a layman's concept of TB treatment is better known as dots. That is the directly observed treatment, short course chemotherapy using the intermittent regime. It came up in 1993, but it was incorporated into the revised National Tuberculosis Control Program in the year 1997. So, if we see RNTCP, now it is known as National Tuberculosis Elimination Program. This rechristening or renaming of the program, it came up very recently, last year only, in the year 2020. But before that, from 1997 to the year 2020, it was RNTCP, Revised National Tuberculosis Control Program, and this DOTS was incorporated in the year 1993. So, in a nutshell, we started our journey right from 1947 till date in the form of National Tuberculosis Elimination Program.
Right. Sir. And as you said, that National TB Elimination Program, previously known as Revised National Tuberculosis Control Program, has seen tremendous changes in the last 5 years. Can you please elaborate about those changes and update us on the recent advances?
Yeah. These changes which you are telling about, yes, it's true that many changes. The program was not that flexible earlier when it was even in the RNTCP, Revised National Tuberculosis Elimination Program. It was not that flexible. But in the last 5 to 6 years, in fact, when the National Strategic Plan 2012 started till 2016, then the 2017 we had the NSP, National Strategic Plan 2017 to 25. During that phase, there was a lot of changes. The first was the National Framework for Tuberculosis and HIV, in which HIV testing is offered to all the TB patients. We all know that tuberculosis is the most common opportunistic infection in HIV patient. So HIV testing was made mandatory for all the TB patient and vice versa. I mean, all the HIV patient TB test was made mandatory. Then we had the intensified TB case finding at the ICTCs, ART, and the community care center. Then there was linking of the HIV infected TB patient to NSCP, that is National AIDS Control Program for HIV care and support. And also the provision of co-triamoxazole prophylactic therapy, that is CPT, for HIV infected patient, TB patient. Now, as I told you, the National Strategic Plan 1 2012 and 2016, the government made TB case notification mandatory even from the private sector. But though it was made mandatory way back in 2012, but till recent year in the NSP2, nobody bothered. I mean, the private sector did not bother to notify any TB cases that they are treating. So this mandatory notification from the private sector, even from the private sector, government sector is doing notification. But the private sector notification, it was made mandatory in 2012, but that came into effect very recently, just 2 years back. Then in 2012, the serodiagnosis was banned by government. I mean, it was useless. So there was no use for any serodiagnosis. We are having molecular diagnostic method, microscopy, X-ray, and all those. Then the Nikshay portal was set up. It is a web-based application. It was created to create a database for all the TB cases and also for the programmatic management of the beneficiaries. Then we have in 2014 something very important and remarkable, that is called the Standard for TB Care in India. So this there was a meeting among all the stakeholders, including WHO, Government of India, private practitioner, all the stakeholders, and we came up with a module called Standards of TB Care, and that was the prototype for changing the intermittent therapy under dots in the RNTCP to the daily dots. That was the basis, the standard for TB care, which came up in 2014. Then in the year 2014, we have the famous NTB strategy, and you might be knowing that India has opted this NTB by the year 2025, about 5 years before the Sustainable Development Goal target of 2030. Then NTI, that is National Tuberculosis Institute, Bangalore, it conducted the first and the largest national drug resistance survey during 2016-17. Then we have the National Strategic Plan from 2017 to 2025, where lot of changes came up. That was the main changing phase in the NSP.
Sir, and what are the operational difficulties faced by our health workforce
Okay.
engaged
Uh,
with the TB elimination, and also the difficulties faced by the patient and their relatives?
Okay, okay. So before I go into the operational difficulty, let me tell something about the National Strategic Plan 2, that is 2017 to 25, because that was the period where the maximum changes took place, and because of those changes, those operational difficulty that you are telling regarding the patients, from the patient perspective, from the our health worker perspective, that came up because of that change. So in the year 2017, we started with the NSP, National Strategic Plan, which will continue till the NTB target of 2025. So it has got four pillars. One is detect, one is treat, prevent, and build. So just remember, there are four pillars: detect, treat, prevent, and build. Under detection, we have got the active case finding. Previously, tuberculosis was diagnosed passively. I mean, any patient, any symptomatic patient used to visit the health center with symptoms of cough or fever, and yeah, they used to get diagnosed in that way. That was a passive reporting. But now active case finding are also taking place. It's a screening activity in the vulnerable high risk group, like the socially backward classes, the prison inmates, the diabetics who are more vulnerable for getting TB, the household contacts. So there is active case finding among those vulnerable groups. Then came the notification of all TB cases. As I told you, way back in 2012, notification was made mandatory, but nobody bothered among the private sector for notification. So there is something called stick and carrot policy. So जब carrot से काम नहीं बनता है, then we go for the stick policy. So this notification of TB cases, which was formulated way back, made mandatory way back in 2012, it did not came up. Then in the year 2018, it was put under IPC Indian Penal Code section 269 that if somebody does not notify a case of tuberculosis, then he or she, whether he is a medical practitioner, a doctor, or a pharmacist, whoever he might be, they may get penal action against them, and there might be they may put behind the bar also. And we can see that the notification of the cases after this has increased much from the private sector, who were not notifying. Even this notification came up some 9 years back. Then we have H1 implementation, H1 scheduled drug. So anti-TB drugs are H1 scheduled drug. And H1 drugs, as per the Cosmetic Act of 1940, it can be sold only based on the prescription of the registered medical practitioner. And pharmacists have to keep a record of those prescriptions and the selling of the H1 drug. So what happened? You can see when this H1 drugs cosmetic act it was implemented for anti-TB drugs, anyone selling those drugs, if there is a check in the register and we come to know that they are selling the drug, then we can trace back who has prescribed those drugs, because you cannot sell those drugs over the counter. Somebody has to, some registered medical practitioner has to prescribe those drugs. So we can trace back and we can find out whether that private practitioner has notified the case, which is again mandatory. So there is a link between H1 schedule register and the notification. If some private practitioner does not notify but write a prescription, and that prescription goes to the pharmacy, and the pharmacy has to mandatorily keep the H1 register, and when that register get checked, and we can find out which private practitioner they are not actually notifying the case. So this was the H1 register. Then with early diagnosis and treatment, the microscopy center were increased to improve the access. And what most importantly it came is the universal drug susceptibility testing, that we call universal DST. All over the country, all the TB patient to be tested for rifampicin resistance by CBNet machine. If we see the testing of tuberculosis, earlier we had many categories. I mean, the treatment protocol was category 1, category 2, category 3. And if you see that we had to wait for 6 to 8 months for declaring a patient to be drug resistant. And by that 6 to 8 months, what happens? Those patients might have already communicated that disease to so many other people, and that disease was a multi-drug resistant disease. Now what is happening? Now, right at the inception, at the beginning, once a TB case is diagnosed, either clinically or by sputum microscopy, they are done. All the TB cases are mandatorily put under CBNet for rifampicin resistance. And if the rifampicin resistance it comes out, then it is further drug susceptibility testing is done by the second line LPA or the line probe assay, and also by the solid and the liquid culture. And even if it is rifampicin sensitive, Then also it is again sent for the INH sensitivity monoresistance by the first line LPA. So you can see that the diagnosis of drug resistant TB, which earlier used to take about 6 to 8 months, now it is getting diagnosed right at the moment. So it is preventing the spread of drug resistant tubercular bacilli to other people. Now there are some. I was talking about the carrot and the stick policy. So that was a stick policy that I told you. Now rupees 5,000 is being given for the completion of treatment, and drug resistant case rupees 5,000 is being given. Then incentive for informant rupees 500 for reporting a confirmed case, and rupees 500 for reporting a treatment outcome. Now, coming to the second pillar of NSP2, I'm telling you in details because before we understand the operational difficulty, you should know what are the things that have come up in NSP2, that is the National Strategic Plan. That's why I'm telling in details. Now, the second pillar in treatment, we have the daily regimen, daily dose of fixed dose combination. It was started in 2016. It was started with 5 states, and at that time I was in Sikkim, and Sikkim was one of those pioneer 5 states where these daily dots, the concept of daily dots was there, and I was the organizing secretary of that daily dots, what it is called. Workshop for Sikkim. Then we had something called Nikshay Poshan Yojana. So we know that malnutrition and tuberculosis, it is a vicious cycle. How it is vicious? Malnourished people, they are immunocompromised. It leads to more preponderance, or they are more vulnerable for tuberculosis, and tuberculosis, it leads to malnutrition. So it's a vicious cycle. And government of India, in 2018, in the NTB summit that was held in March 2018, where our honorable Prime Minister came at Delhi Vigyan Bhavan, I was also present there. So it was announced this Nikshay Poshan Yojana, where rupees 500 is given to the TB patient per month, so that the patient can buy nutritious food for himself, so that he can prevent himself getting malnourished, and end this vicious cycle. Then coming to the prevention, the third pillar of the prevention, we are having airborne infection control. We are having the recent guideline that came up in the last week of July 2021, the programmatic management of TB preventive treatment in India, that is by the 6 months isoniazid, or 3 months isoniazid and rifampicin. That is weekly therapy, isoniazid with rifampicin. That is a new drug that has come up for the latent TB cases. Then those are the strategy. We are having the national TB prevalence survey. We are having the latent TB infection and management. So many things have come up. That is, I think, clear for you and our audience, that many things have come up. Now I will come to your question, that what are the operational difficulty? Because this question is linked to the new things that have come up. Now the operational difficulty is that still after so many changes, we are not being able to reach many of the hard to reach area, like the migrant population, like the hilly areas, the riverine island in the places like Assam and all. So those are our challenges. And also we have a huge reservoir of latent TB infection, which is another challenge, though it has been taken up by the program. But once we treat the latent TB, we will ensure that the person will not be reinfected. Yes, the person is suffering from latent TB. No, but he has to get, he can get reinfected also. So those are the thing that is coming up, and also that rupees 500 that is given for Nikshay Poshan Yojana. can you ensure that the person will spend that rupees 500 only for the nutritional aspect? He might spend for other pressing needs of his family. Who can ensure कि वो 500 रुपया उसके खाने पीने में खर्च होगा? Nobody can ensure. We are giving 500 rupees. So it was always better to give some nutritious food,
Right.
ready to eat food, rather than giving an amount of rupees 500, which we cannot ensure that the person will use for his nutrition. He might use it for other purposes also. And lastly, our healthcare workers are very limited, those who are working in the field of TV. Now, so many new things have come. They have to do multitasking. I mean, managing the various incentives for the beneficiary using the Nikshay portal. So it is diluting the field activity of our healthcare worker, and it is going to have some effect on the treatment adherence for the patient. So those are the operational difficulty that we are facing from the patient perspective, from the health worker perspective, because of all the changes that have come up in the last 5 years. And let me tell you another thing: changes are coming so fast that our healthcare worker, including doctors, it is very difficult to come in pace with the changes. Matlab, some guideline was there just 6 months back. That guideline we took training, again it got changed. Now again retraining. So it is very difficult to cope up with those changes if the changes come very fast. So I think hopefully I have answered your question regarding the
Right.
difficulties.
Thank you, sir. And lastly, what is your view about India's NTB target by 2025, which is 5 years before the Sustainable Development Goals global target of 2020-30, as you have already said?
Yes, yes. So, as I have also mentioned that India's NTB target is 2025. This is 2021. सिर्फ 4 साल
Right.
बाकी है. Only 4 years is left. And
Right, sir.
let me tell you, through you, let me tell to my audience that 27% of the global cases of tuberculosis are there in India only. So, one fourth, more than one fourth of the total tuberculosis cases, India harbors that. Those includes the drug sensitive and the drug resistant cases. It was very pragmatic on the part of government of India to declare NTB target of 2025. And if I could not show any slide, but there is a trajectory that if we are to achieve that target of 2025, leave about 2025, 2030, the world target. If we are to achieve, we have to do something which will lower the curve to achieve. Otherwise, even in 2050 also we won't be able to achieve. So the changes which I was talking about, those are the changes that have come up, so that the trajectory which is now, which we cannot even complete in 2050, those new changes are hoped to lower the curve so that we can achieve in 2025. Now, I should not discourage our health workers or our program by telling that no, we cannot achieve in 2025. Nothing is impossible. Nothing should be impossible in anyone's dictionary. We are towards the target. We have reduced the burden to a large extent. We are doing many new things. Latent TB prevalence survey, latent TB infection management. We are doing many new things, and hopefully we will be able to do. We would have been able to do by 2025 if this COVID pandemic would not have come. क्योंकि this COVID pandemic has really put us back by 2 years. Because for exactly 1 year, nothing could be done. Nothing could be done. In fact, it has affected our not only in tuberculosis control but overall health program has been affected. So, but I still hope, if not 2025, but at least by 2027 or latest by 2030, that is the SDG target, we'll be able to do. Some states like small states like Sikkim, they have declared 2022. Then Himachal had declared 2021 their state target of NTB, but they are nowhere near that target. So I think you can imagine. I won't discourage anybody. We are on the right path, but it might not be practically possible to have this NTB target by 2025. I am hoping all the best. Fingers crossed. But let me wish all the best from my side to all our health workers so that we can achieve this target by 2025 or by latest 2030.
Thank you so much, sir. We have talked so much technical things, and just in the end of the video, एक common people के कुछ questions जो मेरे दिमाग में आ रहे हैं सबको बताने के लिए कि जैसे एक टीबी है तो कब किसी पेशेंट को या किसी भी इंसान को कब डॉक्टर के पास विजिट करना चाहिए, कितने दिन तक की खांसी होने के बाद, या कैसे कैसे उसको पता चलेगा कि अब हमें जैसे अभी सर्दी जुकाम का मौसम चल रहा है तो अभी कितने दिन बाद कितने दिन तक की खांसी हो उसके बाद इंसान को डॉक्टर के पास विजिट करना चाहिए?
देखिए, अभी तो खांसी होने से एक ही चीज याद आता है, वो है कोविड. So TB and other respiratory infection has taken a backseat in this scenario. मतलब खांसी होने से ही दिमाग में वही आता है. So आपका क्वेश्चन बराबर है. As per the program, it is 2 weeks. We tell it as 2 weeks of cough. पहले 3 weeks था, विथ फीवर था. अभी हम उसको मतलब कम करते जा रहे हैं ताकि हम पेशेंट लूज ना करें. लेकिन मुझे लग रहा है कि किसी का भी खांसी हो और वो खांसी एक हफ्ता में भी ठीक नहीं हो रहा हो, मतलब दवाई भी लिया हो, एंटीबायोटिक्स, फिर भी इट इज नॉट गेटिंग क्योर और हल्का हल्का सा फीवर है, there is loss of appetite, तो we should immediately visit. टीबी इज नो मोर ए स्टिग्मा. टीबी अभी स्टिग्मा नहीं रहा. पहले जैसे लोगों को टीबी हो गया तो मतलब छुपाने वाला बात था, अभी ऐसा बात नहीं है. तो इट इज नॉट ए स्टिग्मा, इट इज फुल्ली क्यूरेबल. इट क्यूरेबल. मेरे हिसाब से अगर आपका खांसी प्रोग्राम के हिसाब से 2 हफ्ता, लेकिन मेरे हिसाब से 1 हफ्ता में अगर खांसी ठीक नहीं हो रहा हो तो आप कोई भी डॉट सेंटर में चले जाइए, कोई भी माइक्रोस्कोपी सेंटर में चले जाइए और अपने खेकार का जो है अपने थूक का जांच कराइए. ये बहुत इंपॉर्टेंट है. अर्ली डायग्नोसिस बहुत इंपॉर्टेंट.
अच्छा सर, कोई एज है मतलब किसी कोई स्पेसिफिक एज ग्रुप है या किसी भी एज ग्रुप को ऐसा, मतलब अगर छोटा बच्चा है 6 महीने का या 60 साल का कोई है सीनियर सिटीजन, किसी को भी ये हो सकता है या कोई स्पेसिफिक एज ग्रुप में ज़्यादा कंसर्न होने की नीड है?
टीबी एक ऐसी बीमारी है जो कोई भी एज को नहीं छोड़ता है और कोई भी बॉडी के ऑर्गन को भी नहीं छोड़ता है. हाँ, हम तो सिर्फ पल्मोनरी टीबी, लंग टीबी जानते हैं, लेकिन बोन टीबी होता है, ब्रेन टीबी होता है, इंटेस्टाइन का टीबी होता है, बच्चादानी का टीबी होता है, कहाँ का स्किन का टीबी होता है, मतलब एनी ऑर्गन्स में भी अफेक्टेड. जहाँ तक एज की बात है, देखिए मैं एक बात क्लियर कर दूं, टीबी से, ट्यूबरकुलोसिस से इन्फेक्ट होना और टीबी बीमार होना दोनों अलग चीज है. इंडिया में करीबन 30% पॉपुलेशन टीबी से इन्फेक्ट है. हो सकता है कि मैं और आप भी पॉजिटिव हो टीबी इन्फेक्शन, लेकिन इसका मतलब ये नहीं है कि टीबी बीमारी हम लोग टीबी बीमारी. इन्फेक्शन इज सेपरेट फ्रॉम सफरिंग फ्रॉम ट्यूबरकुलोसिस डिजीज. दूसरे डिजीज में ऐसा नहीं होता है. दूसरे डिजीज में इन्फेक्शन का होने का मतलब ही होता है कि मैं उस बीमारी से सफर कर रहा हूं, लेकिन टीबी में थोड़ा अलग है. तो बच्चों में इन्फेक्शन होता है, लेकिन बच्चों में जो टीबी मेनिंजाइटिस जो है, मतलब दिमाग वाला जो टीबी है वो बहुत खतरनाक है. और एक है पूरा शरीर वाला टीबी, मिलियरी ट्यूबरकुलोसिस कहते हैं. इसलिए हम जो बीसीजी का टीका लगाते हैं, ये बीसीजी का टीका बच्चों के टीबी से हिफाजत करने के लिए ही लगाया जाता है, बड़ों में ये काम नहीं देता है। सो बीसीजी इज गिवन टू प्रिवेंट चाइल्डहुड ट्यूबरकुलोसिस, बच्चों वाला टीबी जो बहुत खतरनाक है। और जब भी हमारा इम्यून सिस्टम कमजोर हो जाता है, इम्यूनिटी कमजोर हो जाता है, कब इम्यूनिटी कमजोर हो सकते हैं? एक आदमी जिनका उम्र हो गया है 70 साल 80 साल, बहुत तब खाना खाना पीना भी कम हो जाता है और नेचुरली बॉडी इम्यूनिटी कम हो जाता है, या कोई क्रॉनिक डिजीज जैसे डायबिटीज है या दूसरा कोई क्रॉनिक डिजीज जिसके लिए उसको स्टेरॉइड लेना पड़ रहा है, या कोई बीमारी जैसे कैंसर है तो एंटी कैंसर ड्रग्स ले रहे हैं, तो ये सारे जो कारण है इम्यूनिटी कम होने का, तब जिनको इन्फेक्शन हुआ था लेकिन टीबी नहीं हुआ था, वो इन्फेक्शन उभर के आ सकता है। दैट मीन्स द पर्सन विल बी सफरिंग फ्रॉम द डिजीज। या किसी को इन्फेक्शन हुआ ही नहीं था तो इन्फेक्ट भी तब हो सकता है और डिजीज भी तब हो सकता है। तो ये एक्सट्रीम ऑफ एज वी शुड बी वेरी केयरफुल।
Okay. And sir, जैसा आपने बताया अभी, there are so many TBs like bone TB and uterus TB, skin TB. So is this also communicable, or it is only the respiratory TB is only
वेरी
communicable?
वेरी गुड क्वेश्चन। क्योंकि ये जो पल्मोनरी टीबी होता है जो लंग को अफेक्ट करते हैं, जिसको हम पीटीबी कहते हैं, पल्मोनरी टीबी, यही है कम्युनिकेबल। बाकी ट्यूबरकुलोसिस जो है उसको हम एक्स्ट्रा पल्मोनरी टीबी कहते हैं। टीबी लिम्फ नोड, टीबी स्किन, टीबी बोन, टीबी इंटेस्टाइन, तो ये एक्स्ट्रा पल्मोनरी टीबी होता है। ये ऐसे फैलता नहीं है, इट डज नॉट स्प्रेड इन दैट वे। सो वी आर मोर केयरफुल इन केस ऑफ पल्मोनरी टीबी, जो लंग वाला टीबी होता है जिसमें खांसी वगैरह होती है। ये इससे हमको थोड़ा वी हैव टू टेक द प्रिवेंटिव मेजर्स हमको लेना चाहिए, ये ज्यादा कम्युनिकेबल है।
सर, सब सारे टीबी को रजिस्टर करना अभी मैंडेटरी है जैसा आपने बताया, या मेनली पल्मोनरी टीबी को ही?
नहीं, देखिए मैं पेशेंट हूँ, सपोज मैं पेशेंट हूँ, तो मेरे ऊपर कोई कानूनी दांव पेच नहीं है, कोई धारा नहीं है कि मुझे जाना पड़ेगा, नहीं तो मुझे जेल भेजा जाएगा। ये तो मेरा अपना माई हेल्थ और मेरे परिवार के लोगों का हेल्थ, मेरा आजू बाजू जिनके साथ मैं उठता बैठता हूँ उनका हेल्थ का कंसर्न है। मैं अगर थोड़ा भी मुझे शक हो, एक हफ्ता से खांसी, 10 दिन से खांसी, थोड़ा थोड़ा बुखार हो रहा हो और मैं इसको लाइट ले रहा हूँ, इफ आई कम आउट टू बी ट्यूबरकुलोसिस पॉजिटिव, तो तब तक मैंने कितने को ये किया होगा। तो इसमें कोई कानूनी बात नहीं है। लेकिन अगर मैंने किसी को दिखाया, अगर सरकारी में दिखाया, तब तो वो ऑटोमेटिकली नोटिफाई हो जाता है, रजिस्टर हो जाता है। लेकिन अगर मैंने प्राइवेट को दिखाया, मैं मना नहीं कर रहा हूँ प्राइवेट को दिखाने के लिए, लेकिन प्राइवेट को दिखाने के बाद अगर वो प्राइवेट प्रैक्टिशनर या डॉक्टर उसको नोटिफाई नहीं करते हैं, तो ये जो है ये जुल्म है। दिस कम्स अंडर इंडियन पेनल कोड। तो आम पब्लिक के लिए नहीं है, ये हमारे जो डॉक्टर्स है या हेल्थ वर्कर्स है उनके लिए दिस कम्स अंडर द इंडियन आईपीसी।
ओके सर, एक लास्ट क्वेश्चन सर, कितना मिनिमम और मैक्सिमम टाइम लग सकता है इसको क्योर होने में, टीबी को?
अभी जो हमारे ट्रीटमेंट प्रोटोकॉल है, देखिए टीबी दो तरफ का है। एक है ड्रग सेंसिटिव टीबी, जिसमें जो दवाई हमारा फर्स्ट लाइन ड्रग्स है वो हम आसानी से ले सकते हैं। अभी तो वो इंजेक्शन वाला, नाउ ऑल द टीबी ट्रीटमेंट इज इंजेक्शन फ्री। अभी इंजेक्शन फ्री, चाहे ड्रग सेंसिटिव टीबी हो या ड्रग रेजिस्टेंट। ड्रग रेजिस्टेंट जो टीबी है, जिसमें दो तरह का होता है, एक मल्टी ड्रग रेजिस्टेंट और एक एक्सडीआर, एक्सटेंसिव ड्रग रेजिस्टेंट। ये मल्टी ड्रग रेजिस्टेंट का जो मतलब ड्यूरेशन है, 12 महीने से 18 महीने भी लग सकता है। आजकल शॉर्ट कोर्स भी मिलता है, लेकिन वो शॉर्ट कोर्स तब था जब वो इंजेक्शन वाला था। अभी इंजेक्शन फ्री हो गया है तो थोड़ा फिर लंबा हो गया है, तो समझिए कि 18 महीना। ये मैं बोल रहा हूँ मल्टी ड्रग रेजिस्टेंट। जो थोड़ा खतरनाक है, और एक्सटेंसिव ड्रग रेजिस्टेंट है, जो हमारे सेकंड लाइन ड्रग्स है एमडीआर के लिए, वो भी रेजिस्टेंट अगर हो गया, खुदा ना खास्ता किसी को ना हो ऐसा, तो फिर और लंबा चल सकता है, 2 साल, 1.5 साल से 2 साल। लेकिन जो आम टीबी होता है, जो आम आदमी को होता है, जो ड्रग सेंसिटिव, मतलब कोई रेजिस्टेंस रेजिस्टेंस नहीं, वो तो 6 महीने का, मैक्सिमम 6 मंथ्स का उसका ये है, डेली वो 6 महीने लेने से द पेशेंट कैन बी क्योर्ड। प्रॉब्लम है ड्रग रेजिस्टेंस का।
Okay, thank you so much, sir. Thank you so much for sparing your valuable time and sharing your knowledge with us. It was very great meeting with you. Thank you so much, sir, from the team IAPSM.
Thank you also, thank you for giving me this opportunity.
Thank
Thank
you,
you.
sir.